Good morning, everyone. I am Dr. Vijeta, and today we'll continue our discussion of ovarian reserve and its assessment. Last class, we discussed that ovarian reserve can be broadly divided into the biochemical tests, ultrasonographic tests. Biochemical tests can be further divided into early follicular measurement, that is done on the day 2 to day 4 of the cycle. Cycle-day independent can be performed on any day of the cycle, and provocative test. Example of provocative test is clomiphene citrate challenge test. So before going to the test, we'll just want to know the basic follicular structures of the ovary. So this is the diagram showing the ovary. The outer is the cortex and the inner part is the medulla of the ovary. In the cortex, there are many follicles. The first is the primordial follicle. Primordial follicle is lined by single layer of granulosa cell and it is gonadotropin independent. Coming to the primary, then it develops into the primary follicle followed by pre-antral and antral follicles. So the pre-antral follicle is identified by the presence of zona pellucida and it has multiple layer of granulosa cell. Also, it is gonadotropin dependent as compared to the primordial follicle, which is gonadotropin independent. Then coming to the antral follicle is known as antral follicle because it has fluid-filled cavity. Then after antral follicle, there is pre-ovulatory follicle, which will rupture and lead to the formation of the corpus luteum. Let's now discuss the biochemical tests. Biochemical test can be either direct measure of ovarian reserve or indirect measure of ovarian reserve. The direct measure of ovarian reserve, as we have seen that the antral follicle and the pre-antral follicle will secrete AMH and inhibin. So the direct measure of ovarian reserve is AMH and inhibin B. Coming to, as we seen that the number of ovarian follicle decline with age, both the AMH and inhibin B concentrations also decline. This we have discussed about the direct test. Indirect measure of ovarian reserve. Let's first discuss the concept behind this. So, this is the hypothalamus, pituitary and ovarian axis. Hypothalamus will secrete GnRH, pituitary will secrete FSH and LH, leading to ovary will secrete estrogen and progesterone. So if there is decrease in the ovarian reserve, there will be less secretion of AMH or inhibin level, lead to the decrease in the negative feedback. So if the negative feedback is decreased, this will lead to increase in the pituitary FSH. So this pituitary FSH is the indirect measure of the ovarian reserve. Let's answer one question, why there is short cycle in decreased ovarian reserve? Or we can say the alternate question is why there is shorter cycle in women approaching menopause? So the explanation why women with decreased ovarian reserve have shorter cycle is explained in the following flowchart. So because of the decreased ovarian reserve, the central negative feedback will be decreased, lead to increase in the pituitary FHH secretion, which will lead to the increase in the early follicular FSH concentration, which thereby lead to earlier increase in the FSH. As the FSH will increase early, there will be early development of the follicle growth and increase in the estradiol concentration. This whole thing will cause the length of the follicular phase shorter and lead to the overall cycle shorter. Thus, we have discussed the physiology, the concept about the type of follicle, primordial follicle, primary follicle, pre-antral follicle and antral follicle.
will discuss the important ovarian reserve test, that is AMH. Discuss about the important ovarian reserve test, that is anti-Mullerian hormone. So anti-Mullerian hormone is secreted by the granulosa cell of preantral and small antral follicles. The beginning of the secretion occur by the when the primordial follicle start developing into primary follicle, and the secretion will end when the antral follicle reach the size of 2 to 6 mm. So the secretion is mainly by the primary follicle and pre-antral follicle and early antral follicle, which is less than 2 mm diameter. Let's come to the clinical significance and how the correlation of ovarian reserve with the AMH. So, AMH correlate with the number of small antral follicles. If there is decrease in the follicles, then there will be decrease in the AMH level. And at the time of menopause, when all the follicles go into atresia and there is no follicle left, it will approaches to zero. So, um, the importance of AMH is that it is gonadotropin independent and exhibit a little intracycle as well as intercycle variation. So, it can be done on any day of the cycle. We don't need to do it on day 2 to day 4 of the cycle. And the other important thing is that the kit which are used to measure AMH has a very low inter-assay variation, that is less than 10%. It doesn't vary much. Like if you have underwent this test from one lab and other lab, so it will not, like in one lab it is 2 and other lab it is 6. The variation is only less than 10%. Coming to the little statistics part of the.
Let's discuss the statistics, that is the positive predictive value, the sensitivity, and the specificity of the test. AMH has a, if the value of AMH, that is the threshold of AMH, is taken as low, then it has a very high specificity. It approaches about 78 to 92%. As we know, if the specificity increases, then sensitivity obviously goes down. So it has a low sensitivity, that is 40 to 97%. Negative predictive value is 97 to 100%. So the meaning of this is if the patient has low AMH, that is below the threshold level, then it is most likely that the woman will respond poor to the stimulation protocol. But this does not tell us that the patient will not get pregnant. So it is not sensitive as well as not specific for predicting pregnancy. So I have just told you the inference, that is low threshold values have good sense specificity for poor response to the ovarian stimulation, but not for predicting pregnancy. So if we cannot exclude the patient, if the patient has 0.1 AMH, we cannot exclude the patient that you need donor oocyte. We need to try for the patient for IVF or ICSI. We cannot solely based on the AMH value exclude the patient from IVF or ICSI. Now let's discuss about the implication of AMH. So AMH is very important screening test for decreased ovarian result. As we have discussed, it has a very high specificity in general IVF patient or women at high risk of decreased ovarian patient. But it is not that much specificity for patients who are not having any infertility problem or which are low risk of decreased ovarian result. There is no consensus on the threshold value. That is, we have not identified a threshold value below which we can say that this is decreased ovarian reserve. That or there are chances of poor response to the stimulation. So we have not found that value till now. And AMH in patients without infertility do not correlate with future fertility potential.
young patient who is not who doesn't have any infertility issue underwent an AMH test, it how it is like 1.2 or 1.3, it doesn't correlate with the that she will not get pregnant or she will suffer from infertility or poor ovarian reserve. That the because the specificity is very low in patient who do not have any infertility issue or who are not at a risk of decreased ovarian reserve. So it should not be used to predict the reproductive status or the onset of menopause in patients who are not having any infertility issue. Let's discuss the factor affecting it, the AMH value. So the patient on oral contraceptive pills like Mala N and Mala D, these AMH value may be decreased. So we have to take a caution before interpreting these AMH results. So the summary of today discussion is that ovarian reserve markers should not be used to promote planned oocyte cryopreservation. The decision for oocyte cryopreservation should be based on the woman reproductive plan and age is the most important or stronger predictor of reproductive success than any ovarian reserve test. So if the patient underwent an AMH test at the age of 25 and it comes low, then we should not promote the oocyte cryopreservation. Okay, it should be based on the plan and the age of the woman. So this is about AMH. In the next class, we'll discuss about other ovarian biochemical ovarian reserve tests. So I hope you enjoyed the lecture. Thank you.